Good morning. Hello, everybody. I'm Osama Kandeel, cardiologist from Egypt at National Heart Institute. Today, I'll present my case, which is a challenging case, but this challenge is not related to a special technique of intervention, but related to the stepwise approach for diagnosis of this case. And now let's start with case scenario. My patient is 44 years old male, diabetes, hypertension, long-standing on medical treatment, chronic kidney disease with basal creatinine level 2.2 milligram. 3 years ago, he developed cerebrovascular stroke without any residual effects. 2 years ago, he underwent left-sided aortofemoral bypass surgery due to aortoiliac disease with his vascular surgeon. How he is admitted? He is admitted for elective peripheral angiography plus or minus angioplasty due to chronic lower limb ischemia in vascular surgery department, not our cardiology department. Pre-procedure cardiac assessment was asked to assess the pre-procedure cardiovascular events. And there was no cardiac symptoms, no cardiac signs, no signs of heart failure. ECG show LVH due to chronic hypertension. Echo was asked, and it was the first surprise, showing two masses on the atrial surface of both mitral valve leaflets without stenosis or regurg. Upon which we started the workup of infective endocarditis, including 3 blood cultures at 0.16 hours, transesophageal echo, and empirical antibiotic unit time. And this is a transthoracic echo apical 3 view. You can see two masses on the atrial surface of both mitral valve leaflets. And this is the transesophageal echo done during the same session of transthoracic echo. Here in the diastole window, the two masses appear, and also in systole window. This is a view of, As you see, a transesophageal echo showing two masses on the mitral valve without any affection of the valve function. There is no stenosis or regurg. Another view. The vascular surgeon was not interested for our initial diagnostic workup and went to proceed for his angioplasty, CO2 guided due to chronic kidney disease, and it was the second surprise. Our patient has suprarenal, totally occluded aorta, and at this moment, our question was that, what can cause total occlusion of a large vessel like aorta? And the answer was that just suspicion, not confirmation, maybe large vessel vasculitis. And this suspicion widened our scope of diagnosis to include a systemic inflammatory disease affecting the aorta, causing large vessel vasculitis, total occluded aorta, maybe. The heart, causing a non-infective endocarditis, which is Liebman-Sachs endocarditis, maybe. Affecting also the kidney, causing chronic glomerulonephritis, causing chronic kidney disease. 24 hours later, serum creatinine is raised from 2.4 to 4 milligram per deciliter, and this increases our suspicion, upon which we recommend the following: renal biopsy and autoimmune profile to search for this major inflammatory disease. Showing the third surprise. Immune profile show anti-nuclear antibody was positive, anti-double-stranded DNA was highly positive, lupus anticoagulant of antiphospholipid syndrome was positive, and renal biopsy, which was done by nephrologist, showing irretrievable affection of stage 1 or 2 lupus nephritis. So the final diagnosis of this case was that systemic lupus erythematosus with antiphospholipid syndrome, non-infective endocarditis, large vessel vasculitis, and glomerulonephritis. The patient started steroid immunosuppressant oral anticoagulant therapy, and the plan was to do open surgery for his aorta or angioplasty. But unfortunately, our patient developed severe psychological depression due to this sudden tough diagnosis, because for more than 3 years he was treated with his vascular surgeon as a simple case of atherosclerotic peripheral vascular disease, but the actual diagnosis was totally different, was a totally different management plan. He was diagnosed as lupus with many complications like vasculitis, endocarditis, and glomerulonephritis and antiphospholipid syndrome, which contribute to vascular occlusion and cerebrovascular stroke, which occurred 3 years ago. Despite psychological therapy, the patient refused any medication. The patient discharged against medical advice from the hospital. We made many trials to call him to come back to the hospital to complete his management plan, but with no reply. The patient, 1 month later, was admitted to us with a very serious complication of lupus, which was acute renal shutdown, sepsis, and very severe sepsis and septic shock, and went on ventilation for 48 hours, and finally, unfortunately, he died because he was depressed, neglect himself, neglect his medication, and it was the final horrible result. So this case was challenging, informing us that don't look to your patient as a limb, but as a whole patient. Don't manage the limb and remove or discard the other systems of the patient. When you return to the literature, you can find that valvular involvement in patients with systemic lupus ranges from mitral valve prolapse to valvular vegetation, consistent with non-infective endocarditis. Lip-and-sac endocarditis can be found in 1 of 10 patients with lupus and related to longer duration, as in our patient, which was having lupus for more than 3 years and not diagnosed, higher disease activity, as also in our patient, and the positive antiphospholipid antibodies also, all these criteria are present in our patient. Also in lupus, vasculitis is seen in 11 to 36% of patients. A small vessel vasculitis is seen in about 86%, and the medium vasculitis is seen in the rest. And where the large vessel vasculitis, it's very, very, very rare to see large vessel vasculitis in patients with lupus, up to 1 every 100,000 of patients. So it's a very, very rare case and unique presentation. Large vessel involvement in lupus predominantly involved the aorta, as in our patient, causing totally occluded aorta, and subclavian arteries, and associated with high disease activity, as in also in our patient. So we present in such a case report a patient who was treated for more than 3 years as atherosclerotic peripheral and cerebrovascular disease, and the actual diagnosis is lupus with a unique presentation involving the aorta and mitral valve. So my take-home message is teamwork and stepwise approach for diagnosis exactly can save your life, your patient's life, and don't look to your patient as limb or a vessel, but as a whole patient. Thank you.
Thank you. I think it's always important from time to time to remember that there are other diseases that can affect the vessels that actually don't need stents and interventions. So this was a good reminder. Vasculitis is one of the toughest diagnoses to make, but always think about it when you have patients, especially young, with large vessel disease. We've been burned as well on these, so it's good to remember.
Yeah.
It's good to remember that. Any suggestions? Any discussions?
Excellent case. Just wanted to ask you, pardon my ignorance, but basically the anticoagulation is for Lipman-Sachs endocarditis to prevent thromboembolic events?
Yeah, also for another indication, which is antiphospholipid syndrome, is indicated for long life anticoagulation. So this patient was indicated for anticoagulation from more than 3 years. Just one steroid therapy and oral anticoagulant for more than 3 years can save all this. Can save the patient from all this complication.
I don't know if I'm right or wrong, but I think in SLE patients, some patients can have this antibody to be positive, even though they don't necessarily have antiphospholipid antibody syndrome. So it's like part of the, I think so. I'm not 100% sure on that, but yeah, thank you. Other comments?
No, I think it was a great case, and I find these patients with SLE and antiphospholipid particularly difficult because they, a little bit subtherapeutic and they thrombose everything, and then they have a tendency to bleed, and the other thing is I think you had a very difficult situation because when we see patients with large vessel vasculitis and their ESR is 100 and their CRP is 20, that's not the time to do an operation on them. I mean, oftentimes, and I don't have a great experience with this, but usually we'll try to get them by with immunomodulators, or there are some steroids, or even some cytotoxic drugs that they use now. And usually I send them to the rheumatologist to help with this because you really need to control their inflammation before you can even think about trying to do anything else to them. So it was a very difficult case.
I agree with you.
Thank you.
Thank you.